Thank you, panelists. So you can see we're going to have a very rich discussion here. We have about 20 minutes. We'll try to take 10 here for a question that I'll start, and then we'll open it up. So my question, we have the Assistant Secretary here, and he has a busy day, so he ran off, but his office is here. They're listening, so we have a chance to help the office out. So the question is, and we're going to spend the next part of the day focused on health sector interventions. So, and I heard very clearly that the health sector and the community and regulatory environment are very complementary. So the question is, if these health sector investments that are coming up in the next few panels are going to thrive and have strong return on investment, if we had to pick one, so this is going to be tough. One area for the Secretary's office or the Assistant Secretary's office to focus on among all these kind of larger contextual issues, what would you recommend? Or if you want to sidestep the prioritization of which thing to do, what evidence needs to, what do we need to focus on from a research perspective to be able to set that priority? Because we're not going to do everything at once. We'll start with you, John.
Thank you for that question. I would say starting with housing availability and affordable housing would be the priority. And I say that in part based upon, I think, the initial evidence from the accountable health communities and from other healthcare providers that have been using screening devices. That comes up, I think, most often as the impediment to good health. What I would say about that, though, is it's not so simple as to say you need an affordable apartment. It also involves thinking about are there wraparound components of services that are necessary in order for that to be successful, particularly, for instance, with people who may not have had a history of stable housing, people who've been chronically homeless need assistance. It also involves thinking about the neighborhood in which the housing exists, and does it exist in ways that it's safe, that its food is accessible and walkable, and so there are a number of other components to that. But I think housing is key, and also the dilemma with housing is once you fill a housing unit, you've filled it. It's not like a service where there's a lot of turnover, so it really requires a very strong focus.
I think it's a good question. I think it's a question of the day. But one of the things to think about for me, which I was alluding to when I presented, is where a lot of us are already doing work across the spectrum. But the question really to ask is the intention of the work getting to the groups that we need it to get to? So at the Department of Public Health, of course we have to work with individuals at high risk for disease and those who already have disease. And of course we have to work in the communities. But how do we knit that together, and how do we work with our sister agencies to use the levers that they have? So I gave the example of our Attorney General's office, who is also using her community benefits funding. Community benefits is a rich source of resources in states. It's roughly $200 million a year, for example, in Massachusetts. That doesn't all go directly to community services, but there's ways that they are now, starting next year, going to hold healthcare systems accountable for reporting back on where the spend is. We're working with our Massachusetts Medicaid on their initiatives around housing and nutrition, and thinking about how to help the communities be able to assist the healthcare system. We speak a lot about the healthcare system, taking on social determinants of health, but having come from that system, it's really hard if you're in isolation as a primary care physician or a provider trying to, figure out how to get someone housed. So making those connections, it seems like a small thing, but it's a really important part of the work. And, it's harder than we all think to bring those two pieces together.
Can I just follow up for a sec? So I hear you say there's ways we can work smarter, and I heard it in your presentation as well. And you're doing it at the state level, but if you had a recommendation to the feds to say, how can we get all states to work smarter? Is there I'm putting you on the spot here, but is some action step that you might recommend?
One of the most powerful leverage points is to look at where funding is already going. So I think that is happening with the healthcare piece that we heard the Admiral talk about this morning. I would look at the IRAs, but the ACA-based community investments and say, it's pretty loosely defined what each individual state needs to do. And we have templates on how that can be made a more accountable system. Again, it's money that's already going into the system, but can we use it smarter?
Can I just add one other point to that? I think that that there's a need for, within the public health sector, to have specialized people who work on this issue. They don't now. Public health departments like Monica's get categorical funding, disease-specific funding. We need a social determinants unit. And I would put forward that a way to do that the administration might consider is funding CDC with a line item that would create a grant that would go to each state and each large city that would create a social determinants unit so that you would know there's a funded person who could be the convener, get the data together, draw together with the governor's or the mayor's support, all those different departments, so that they're at the table and someone's kind of held accountable to do that. That would be an approach I think that with federal support would be very successful.
And just to piggyback on that, when you look at the way that we're funded at most levels of government, because it's so siloed, it does feel like boiling the ocean because everybody's trying to stay in their lane of funding. So braiding and blending opportunities of funding would be incredibly helpful to move this forward.
No, of course. I agree with so many of the comments that both of you made. I think what I'm watching for, so Secretary Azar, I'm sure many people know, made a speech about social determinants last year where he talked about a number of the interventions, that we're already discussing. And we heard from Admiral Giroir this morning that the value-based care agenda, that pillar is where the funding streams may emerge to actually support that work. So let's see, how that unfolds. I think beyond the funding and to add to particularly what Monica was elaborating, it's about lowering the barriers to partnership because so much of this already does exist in communities, and there's a phenomenon of the healthcare sector just waking up, to some of it, which is real and I think is a good thing, but requires some people who figure out how we can actually bring that coordination together. I really love the example of what's happening with the community benefit dollars in Boston, and I think that is something that could be broadly emulated. It makes me think of something similar that we're attempting to do in New York City, which is, managed care organizations, health plans are also thinking about how do we actually channel our social determinant dollars, if you will. But they're often thinking about them independently. And so anything that can help us solve that collective action problem to actually bring those units together so that there are movements that are not sort of the artisanal approach, to social determinants or community benefit, but actually extends beyond one particular health system or one particular health plan. And the last thing that I'll just mention is that we have to, and I think this is particularly true on the research side, we have to look beyond healthcare spending as well. This is another symptom of the myopia of healthcare. But in fact, there are a lot of dollars that are being spent in the criminal justice, other social service sectors, and it's the same people that we're trying to serve, right? So if we expand the bottom line in a way that actually captures those dollars as well, then we start to think differently about where the locus of change should be.
Thank you. And any follow-ups or answers before we open it up?
I did want to piggyback on that comment about the what is it that the communities need? So as a healthcare system, it may feel easier if you're mandated or somehow need to think about your money differently for housing to just build it and to figure out how to quickly come up with a response or manage care. But there's so much work already happening at community levels. And again, getting back to how we defined our community engagement using national standards of community participation, which you're all familiar with, it's about making sure the community has a real voice at the table, because if our end goal is to work on the social determinants that affect a community and inequities within a community, unless they have capacity and the groups that have been working at their community level for decades to be at the table in a very meaningful way, I don't think we'll get the goal that we're looking for.
If I was going to throw in one last thought, I think, again, I'm thinking about the Admiral's question and what could be done. And I think that what would be terrific to do at the federal level would be to pull together a cross-departmental committee that would be focused on the issue of addressing social determinants of health. He could clearly be the chair of that because he's such a wonderful leader on that topic. But seeing HUD and education and the other agencies all around the table talking about the work they're already doing, and would it be possible to knit that work together with some unified goals, maybe eliminating some of the barriers when it reaches the state or the local level in terms of different grant timelines or reporting requirements, that kind of blending and braiding approach. I think setting an example like that would be a good example for then governors and mayors to replicate at their different levels.
Great point.
That was a great discussion. I know we have a lot of folks who in the audience who might want to chime in. So we're going to spend the last 10 minutes of this session opening it up. There are mics on both sides of the room. And go up to the mic and we'll take the first question. Please introduce yourself and where you're from during your question.
Sure, thank you. Thank you so much for your comments. My name is Dr. Marilyn Link. I'm at Adventist Healthcare Center for Health Equity and Wellness. And I have a question for Dr. Burrell about how you determined the 5% threshold for those community health improvement investments, considering hospitals have different levels of investment, different community benefit dollars, and how they invest their dollars. Even though those are public, it's hard to sort of set a benchmark for how much to actually to invest. So how did the department figure out that threshold?
So the community health investments is an important and unique piece of what we do in Massachusetts. They're completely separate from the community benefits funds. Yeah. So the community health investments have, historically been set long ago at 5%. Importantly, they weren't codified as well as they could be in regulation. So when we did our 2017 reform, we did codify that 5% because it's what the communities and the hospitals had been used to and had been contributing. So it really is an addition to the community benefits, but it had historically been at that level. Now remember, if 5% of, say, a new PET scan or MRI is a small amount, whereas 5% of a $1 billion project for an enhancement of a major teaching hospital is a lot more. So it does vary what the amount we receive is, but it's a significant amount of money that is going to the community anyway. So just to give you a flavor, from 2015 on, it's over $140 million that will be going to the community already. So the question is how to leverage that and use it better to get the community the health they need.
And just to follow up, since you were talking about how the hospitals are now all coordinating, collaborating on their community health needs assessment, how do they then come together and pick those specific priority focus areas, again, because resources look different for different hospitals? How do they sort of pinpoint what they're going to focus on together?
So the community health assessment, this is being done for the first time in Massachusetts, in Boston. So it's a work in progress right now, but there's a lot of overlap in the communities and the communities that need the investments in Boston, and they are figuring out ways to be synergistic for each other. The resources come from the hospital themselves. So it's not a large pool of money that they're all contributing to. It's each individual hospital then working with their population. But the example that I gave you of the hospital that for the first time invested in housing and housing loans and a grocery store, that was one hospital. And voluntarily, the other two hospitals decided to contribute to that project because it met their community health needs as well.
Thank you.
Next question.
Hi, Alex King. I work at the Community Transportation Association. I have a quick comment and then I have a question. First of all, I appreciated the comment about creating a federal organization that would have cross-sector collaboration. I wanted to plug that we should learn from other sectors that are already doing this. The Department of Transportation has the Coordinating Council on Access and Mobility, which is a multi-departmental group that is supposed to be meeting about mobility and transportation, which is a huge aspect in the social determinants of health discussion. Right now, the DOT is the only agency that is mandated to be a part of that. The other departments are not, which means oftentimes it's not taken as seriously. So I would say start with partnerships that are already existing and try and build those versus always starting something new. And then my question is, my organization represents rural and small urban specialized public transit providers all across the U.S. They often provide a lot of healthcare trips or trips to social determinants of health locations, such as grocery stores, things like that. They often feel that it's really hard to break into the healthcare space or to start talking with people in healthcare. Do you have any recommendations that I can take back to kind of help them understand how to get that foothold in the door or where to start, because it can be very overwhelming, especially if you're from a smaller community that's not a big city?
Sure, yeah, I'm happy to start. So yes, healthcare can be hard to break into. That's certainly a lamentable part of what we need to fix, in this conversation. I think my advice is that healthcare is no different than many other sectors in that you get kind of focused on the problems that you're already trying to solve. And so talking about things like, transportation as a way to address imperatives under value-based care or value-based payment is some of the framing, I think, that will help for particularly for transportation interventions. And more broadly, I would just say that that the place to start in healthcare is not always obvious from the outside with respect to organizationally. So our system happens to have a group that is focused on population health and social determinants. Many others do not. And in those cases, potentially starting with someone who is working at a hospital leadership level or a clinic leadership level, it may make more sense to actually get traction.
On the issue of transportation in particular, I think we did have a major event this week with the release by Director Werner of the CMS guidelines that Admiral Giroir was talking about, which actually called out the possibility of paying for transportation for non-medical visits, but for visits that to other kinds of places, maybe to buy food or to that could be paid for with a CMS funding. And the fact that those examples were highlighted and offered, I think, is very valuable as a tool. That said, I think very often Medicaid programs, for example, at the state level are risk averse and nervous about breaking into paying for something that hadn't been paid for before. So I think it having the tool of CMS saying it's possible, married to local advocacy and local visits to the Medicaid department to make the case that transportation is really strongly connected is necessary, but I think we have the door has been opened this week with that the letter that was released, and I'd encourage people to just Google the letter and look particularly for transportation and other non-medical social needs that were highlighted.
Let's Jenny, would you like to ask the next question?
Genevieve Kenny, I'm a researcher at the Urban Institute. This is a really great panel. So Dr. Burrell, I was really excited to hear about what's going on in Boston and absolutely think there are implications for the federal government and federal policy making that could support, incentivize, encourage that around the country. But connecting the dots, I wondered if, and perhaps it's too early in your experience, if you're intending to identify both the opportunities and potential impacts of repurposing and dedicating funds in a more community-centric and forward-looking way, and as well as the challenges. And you mentioned housing in particular, and I think we all are aware of the shortfalls in the funding in the housing sector to meet the existing need. So I'm wondering how far you think we can go with convening, coordination, and repurposing existing dollars in addressing some of these needs.
Mm-hmm. It's a great question. I think you've touched upon a couple of things. One is, I think the first part of your question was asking about evaluation of our work. And as many of you know who have run or been part of state or local agencies at the federal level, the evaluation part is always the hardest, right? Because the money is going out to the community. So it's probably the weakest part of the puzzle in many pieces. And maybe a piece of our recommendation should be to make sure there's strength in that so that we're beginning to answer these questions on return of investment that we're asked all the time. Point one, we will be asking for annual reports back on the community health investments, which include data and statistics, so we'll be able to report on that a little bit. Because this is a Massachusetts-wide program, we won't have a control group within Massachusetts because it's all of Massachusetts that's participating in this.
So I'm getting we're done, but this fine gentleman over here, who I cut off last time, I'm going to give him a chance to ask his question and just maybe have a brief response.
Promise a quick question and a second different one from my earlier. Larry McNeely with American Diabetes Association. If you're thinking about bending the curve of diabetes in the type 2 diabetes in this country, you've got to think about what happens very early in life, which means you've got to think about what happens in the family unit, both during pregnancy, early years. But before that, that is such a collective action problem. It's a collective action problem when costs are high with your seniors who are already acute. How do we get investments? How does the community that's interested in social determinants of health think about getting more investments to that population, young families, youngest children at this point in your communities?
One panelist want to have a quick response?
That's a tough question. I think this gets at Admiral Gerard's, second question as well, and this is the problem of long time frames being a hurdle to making the investments in prevention that we need. And I think we have to start looking at places, the VA was mentioned before, where the incentives are aligned, to be able to make those investments, develop an evidence base around that, and have that drive change more generally. And I'll just give one other thought that's related to this, which is we also have to, I think, kind of resist the allure of innovative pilots, and doing things in a disease-specific way because, the scale at which, those actually are affecting people pales in comparison, I think right now, particularly compared to policy change. So just making sure that we're not in the same breath comparing something like, an app for searching for food banks to, policy changes, for example, work requirements in SNAP, the food stamps program that will lead to 750,000 people, losing their food stamp benefits. So just making sure that we have the appropriate respect for scale in those conversations as well.
Let's thank our wonderful panelists for a great session. Please take your cards and